I am Shuhaila Muhammadali, Assistant Professor from Department of Pharmacy Practice, Yenepoya Pharmacy College and Research Center. Today we will discuss the diabetes mellitus. Diabetes mellitus is a group of metabolic disorders characterized by hyperglycemia associated with abnormalities in carbohydrate, fat and protein metabolism that may result in long-term microvascular and macrovascular complications. Diabetes is a metabolic disorder. Basically, it is related to glucose level in our body. There will be an increased level of blood glucose and it is associated with abnormalities in carbohydrate, fat and protein metabolism. There are basically two main types of diabetes, type 1 and type 2 diabetes. Other than that, there is GDM and two other types of diabetes. Type 1 diabetes mellitus constitute about 9 to 10% of diabetes mellitus. It is also known as insulin dependent diabetes mellitus or juvenile onset diabetes mellitus. Juvenile onset diabetes mellitus means it occurs in young age. In this type of diabetes, there will be an insulin deficiency in our body and it is mainly due to autoimmune destruction of the pancreatic beta cells. It usually occurs in young age, that is below the age of 30 years. Type 1 diabetes is again classified into type 1A and type 1B. Type 1A occurs due to autoimmune destruction of the pancreatic beta cells and type 1B occurs due to idiopathic reasons. That is, the exact reason for this type of diabetes is unknown. In type 2 diabetes, which is the most common type of diabetes, that is 80 to 90% of diabetes is type 2 diabetes and is common in above 40 years of age. It is also known as maturity onset diabetes and non-insulin dependent diabetes. Non-insulin dependent diabetes means there will not be any deficiency of insulin and it is developed due to defects in insulin secretion or insulin resistance or both. Insulin resistance means the effect of insulin will not be there. And the next type of diabetes is gestational diabetes mellitus. It occurs due to glucose intolerance in women during pregnancy. That is, this type of diabetes occurs during pregnancy and it usually disappears after pregnancy. But women who have had this type of diabetes, that is gestational diabetes, had a more chance of getting type 2 diabetes in future. And there are two other types of diabetes, that is latent autoimmune diabetes in adults and maturity onset diabetes of the young. That is, latent autoimmune diabetes in adults is the type 1 diabetes that occurs in individual older than the usual age of type 1 diabetes. Here there will not be any insulin resistance, but there will be antibodies that are present against the pancreatic beta cells that leads to decreased level of insulin. Maturity onset diabetes of the young is type 2 diabetes that occurs in young age. Before moving on to the diabetes pathophysiology, we can look at the normal mechanism that is there in our body for the glucose. The glucose is converted to glycogen by insulin and the glycogen is converted back to glucose by glucagon hormone. These two hormones are produced by the pancreatic beta cells and by the cells islets of Langerhans in the pancreas. The beta cells constitute about 70 to 90% of the islets of Langerhans and this beta cells produces insulin and one other hormone called amylin. This insulin and amylin reduces the blood glucose level in our body and alpha cells in the islets of Langerhans produces the hormone glucagon. Glucagon along with other growth factor, cortisol, epinephrine increases the blood glucose level. So insulin will decrease the blood glucose level and glucagon will increase the blood glucose level. Next we will move on to the pathophysiology of type 1 and type 2 diabetes. Type 1 diabetes is characterized by an absolute deficiency in the pancreatic beta cell function. So, the hormone produced by the pancreatic beta cells, that is insulin, will be less. It is due to autoimmune mediated destruction of the pancreatic beta cells. This causes hyperglycemia, that is there will not be any secretion of insulin. So, conversion of glucose to glycogen will not occur. Pathophysiology of type 2 diabetes. It is characterized by defects in insulin secretion or impaired insulin secretion or insulin resistance. Impaired insulin secretion is due to defects in islet cell function or beta cell mass, and insulin resistance or lack of insulin sensitivity is lack of responsiveness of tissues to the insulin hormone, that is liver, muscles and adipose tissue will not be responding well to the insulin action. So in type 2 diabetes, the amount of insulin will be normal or even high. And impaired incretin production also causes type 2 diabetes mellitus. Incretin are a group of peptide hormones produced by the GI epithelial cells. When we take the food, it decreases the blood glucose level. And in type 2 diabetes, there will be impaired incretin production also. Next, clinical presentation of type 1 and type 2 diabetes. The symptoms of type 1 and type 2 are almost similar, and the common symptoms are polyuria, dry skin, polydipsia, polyphagia, blurred vision, fatigue and weakness. Next, complications of diabetes mellitus. Diabetes mellitus can lead to various complications, and it is mainly classified into macrovascular and microvascular complications. Macrovascular complication, it can affect the brain and causes various cerebrovascular diseases and stroke. In heart, it may lead to coronary artery diseases, myocardial infarction and CHF, and various peripheral vascular diseases like ulceration, gangrene and amputation. Microvascular complications include, in eye, it leads to retinopathy, cataracts and glaucoma. In kidney, it can lead to nephropathy and microalbuminemia. Next, cardiovascular disease, we already said it can lead to myocardial infarction, CHF, due to the atherosclerotic plaque formation. Diabetic retinopathy can lead to blurred vision and blindness, leading cause of blindness above 60 years of age. So it is the leading cause of blindness above 60 years of age. That type 2 diabetes can occur in older individuals and can lead to retinopathy. This diabetes mellitus damage the blood vessels of retina, cutting off its blood supply, and as a result the eye attempt to grow new blood vessels, but this don't develop properly and can leak easily. To develop after 20 years of development of diabetes mellitus. Next is diabetic nephropathy. It can affect the kidneys. It is also known as diabetic kidney disease. It is one of the leading causes of CKD and end-stage renal disease. The diabetes mellitus can affect the blood vessels. We already said in diabetic retinopathy, it affects the blood vessels in retina. Here it is affecting the blood vessel clusters of the kidney, that is glomerulus, and the damage of glomeruli causes the protein loss in urine and causes low serum albumin, resulting in generalized body swelling. So in diabetic individuals, there will be the presence of albumin in urine. Next is diabetic neuropathy. The various types of nerve damage can also be caused by diabetes mellitus. This excess glucose injures the walls of capillaries that nourishes the nerves and causes weakness, numbness, tingling or pain, especially at the tip of toes or fingers, and gradually spreads upwards. One of the main complications of diabetes is foot ulcer. It is a microvascular and macrovascular complication. The nerve damage or poor blood flow to the feet increases the risk of foot complications because of the loss of feeling in foot due to diabetic neuropathy. That is, there will be diabetic neuropathy, so the sensation will be lost. A minor foot sore can lead to ulcers in diabetic individuals. Next is diagnosis of diabetes mellitus. How can we diagnose diabetes? There are various tests available, and it includes random blood sugar test, fasting blood sugar level, postprandial blood sugar level, oral glucose tolerance test, glycosylated hemoglobin and C-peptide test. First is random blood sugar test. The blood sugar concentration regardless of the time of last meal, that is random blood sugar test. We are checking the blood sugar level randomly. A blood sugar level of 200 milligram per deciliter or higher when checking the random blood sugar test indicates diabetes mellitus. Next is fasting blood glucose level. The glucose blood concentration in samples obtained after at least 8 hours of the last meal. That is, after 8 hours of last meal, we have to check the fasting blood glucose level. Here, if the fasting blood glucose level is less than 100 milligram per deciliter, it is normal, and if it is above or 126 milligram per deciliter, it indicates the patient is having diabetes mellitus. Next is postprandial blood sugar. It is the plasma glucose concentration after eating, and the normal value is less than 140 milligram per deciliter. Next is oral glucose tolerance test. Here what we do is, after an overnight fast, 75 milligram of glucose dissolved in 300 ml of water is given to the patient. We will be giving 75 milligram of glucose dissolved in 300 ml of water and is given to the patient. Then the blood sugar levels are tested periodically for the next 2 hours, and a post-load glucose less than 140 milligram per deciliter indicates normal, and 2 hours post-load dose is greater than 200 milligram per deciliter means it indicates the presence of diabetes mellitus. Next test is glycosylated hemoglobin. It is represented by HbA1c. It is glycated hemoglobin doesn't require any fasting, and it indicates average blood sugar level for the past 2 to 3 months. It measures the percentage of blood sugar attached to the hemoglobin. Increase in the blood glucose concentration also indicates increases in the glycated hemoglobin. That is, if the glycated hemoglobin level is high means it indicates the presence of high blood glucose concentration in our body, that is diabetes mellitus. The HbA1c level of 6.5% or more indicates diabetes mellitus. HbA1c is represented by percentage, and A1c level below 5.7% indicates normal, and if A1c level is between 5.7 to 6.4%, it indicates pre-diabetics. Last test is C-peptide test. Fasting blood test is taken to measure the level of C-peptide. Measuring the C-peptide helps to determine how much insulin is produced in the body, because both of these are produced in equal amounts. The normal value of C-peptide test is 0.5 to 2.7 nanogram per ml, and it is used to distinguish between type 1 and type 2, because here we are measuring the insulin level in our body. Last is treatment of diabetes mellitus. The treatment includes non-pharmacological methods and pharmacological methods. Non-pharmacological therapy includes various lifestyle modifications like smoking cessation, stopping the alcohol intake, regular exercises, healthy diet, weight reduction, and maintaining the normal blood glucose level. Next, patient education and various diet plans. Last, the pharmacological therapy of diabetes mellitus. So, for type 1 diabetes, we mainly use the insulin, since there is a deficiency of insulin in our body. The insulin therapy needed balance between tight glycemic control and hypoglycemic risk. That is, if we are taking more than the required amount of insulin means it can lead to hypoglycemia, that is decreased level of glucose in our body. There should be a balance between the glycemic control as well as the hypoglycemic risk. Wide varieties of insulin preparations are available, and it differs in the species of origin, onset of action, time to peak effect, and the duration of action. The insulins can be classified into rapid acting insulin, short acting insulin, intermediate acting insulin, and long acting insulins. It is according to the pharmacokinetics of the insulin. Rapid acting insulin examples are aspart, lispro, glulisin, and for short acting example is regular insulin. For intermediate acting insulin, NPH, and the example for long acting insulin is determir and glargine. And these various types of insulin differs in the onset of action, peak action, and the duration of action. There are various adverse effects for insulins like hypoglycemia, weight gain, thickening of subcutaneous tissue at injection site, and allergic reactions. The site of insulin injection is upper arm, abdomen, buttocks or thighs. Insulins can lead to various drug interactions with other drugs and can lead to increase in the blood glucose level if we are taking insulin along with the diuretics, glucocorticoids, nicotinic acid, oral contraceptives and phenytoin, and can lead to decrease in blood glucose if we are taking it with the alcohol, ACE inhibitors and salicylates. Insulin has to be stored away from heat and light, and it should not be freezed, and the unused bottles, cartridges and pens of insulins have to be stored in refrigerator at 2 to 8 degrees Celsius temperature. Next we will move on to the drugs used for the treatment of diabetes mellitus, that is various oral hypoglycemic drugs. First one is sulfonylureas. The mechanism of action of sulfonylureas is it will stimulate the pancreatic secretion of insulin. There are two main generations of sulfonylureas, first generation and second generation. First generation examples are acetohexamide, chlorpropamide, tolozamide and tolbutamide, and for second generation glibenclamide, glimepiride, glipizide and glyclazide. It can lead to adverse drug reactions like weight gain and hyperinsulinemia and hypoglycemia. The mechanism of next type is meglitinides. The mechanism of action of meglitinides is also the same, that is stimulation of pancreatic secretion of insulin. Examples are repaglinide and natiglinide. ADR of meglitinides include hypoglycemia, visual disturbances and abdominal pain. Next type is biguanides. The mechanism of action is it will increase the glucose uptake, also reduce the hepatic glucose production, thereby decreases the blood glucose level. Examples are metformin. It is a common drug used for the treatment of diabetes. ADR include abdominal discomfort and anorexia. Next type is thiazolidinediones. Examples are pioglitazone and rosiglitazone. They are insulin sensitizers, that is it reduces the insulin resistance in peripheral tissues and liver. So this class of drugs, that is thiazolidinediones, are more beneficial for the treatment of type 2 diabetes, since in type 2 diabetes there is insulin resistance in our body. It can lead to ADRs like edema, weight gain, etc. Next type is alpha glucosidase inhibitors. Examples are acarbose, miglitol and voglipose. Here the mechanism is the alpha glucosidase. It is an enzyme that increases the carbohydrate digestion in our body, and alpha glucosidase inhibitors will prevent the action of this alpha glucosidase. So they prevent the breakdown of carbohydrate and prolong the carbohydrate digestion. So after the breakdown of carbohydrate, the glucose is produced in our body. So while delaying the carbohydrate digestion, the amount of glucose released in our body is decreased. The ADR associated with alpha glucosidase inhibitors are abdominal discomfort and bloating. Next is GLP-1 receptor agonist. Examples are exenatide and liraglutide. It will stimulate the action of GLP-1 and reduces the blood sugar level. GLP-1 is a hormone that helps to reduce the blood glucose level in our body, and the ADR associated with GLP-1 receptor agonist is nausea and vomiting. Next is DPP-4 inhibitors. DPP-4 inhibitors will prevent the DPP-4 digestion, that is GLP-1 is degraded by the dipeptidyl peptidase 4. This DPP-4 inhibitor will inhibit the DPP-4, that is dipeptidyl peptidase. So the degradation of GLP-1 will not occur. We already discussed the GLP-1 help to reduce the blood glucose level. So the amount of GLP-1 is increased while inhibiting the degradation of GLP-1. So the GLP-1 action will be prolonged. The DPP-4 inhibitors decreases the breakdown of ingredients like GLP-1 and reduces the blood glucose level. Example for DPP-4 inhibitors are sitagliptin, vildagliptin, soxagliptin and linagliptin. Next is amylinomimetics. It will inhibit the release of glucagon when eating and slows the gastric emptying. The amylinomimetics is a class of drugs that mimic the action of amylin. We discussed earlier, the amylin will help to reduce the blood glucose level by inhibiting the release of glucagon. ADR associated with amylinomimetics is vomiting and anorexia, and example is pramlintide. Next is the last class of drug, that is SGL2 inhibitors. Example is dapagliflozin, and SGL2 reabsorb the glucose from renal tubules. From the kidney, the glucose is reabsorbed by the SGL2. So while promoting the reabsorption, what will happen? The glucose level in our body will be increased. But these SGL2 inhibitors will inhibit the SGL2, so the reabsorption of glucose from the renal tubules will not occur and the blood glucose level will be decreased. So that's about diabetes mellitus. We said the diabetes is a metabolic disorder mainly characterized by hyperglycemia, that is increased blood glucose level, and it can be classified into type 1 and type 2, and it can be diagnosed by various tests like RBS, FBS, PPBS, OGTT, HbA1c test and the C-peptide test, and it can be treated by various methods that includes non-pharmacological and pharmacological methods. Non-pharmacological methods include various diet plans and lifestyle modifications, and pharmacological methods includes the use of various types of drugs called the oral hypoglycemic drugs. Thank you.